This is Group 6 in N4200 Nursing Ethics, and we are debating the controversial topic of physician-assisted suicide. Group A will be presenting in favor of physician-assisted suicide. Group A includes Daniel Neff, Alyssa Muller, Marissa Wood, and Amber Gase. Group B will be presenting against physician-assisted suicide. Group B includes Taylor Larson, Katie Almus, Julie Turner, and Rachel Kohn. To begin, we will clarify the differences between physician-assisted suicide and euthanasia. Physician-assisted suicide is offering patients medical actions or cessation of actions by which they can end their own life. And euthanasia is defined by the medical practitioner actively inducing death. So we'll start with the first topic of autonomy of the patient for physician-assisted suicide. Autonomy is the capacity of a rational individual to make an informed, uncoerced decision. The key word being uncoerced. Uncoerced means a decision being made using one's own free will without force or input from anyone else. Not being able to partake in the decision of physician-assisted suicide disrespects the autonomy of the patient. John Stuart Mill's thought on liberty and autonomy goes like this: over himself, over his own body and mind, the individual is sovereign.
Well, the argument is that terminally ill people in extreme pain who are conscious enough to make medical decisions have the right to make that autonomous decision for physician-assisted suicide. However, this argument can also be applied to those who are depressed or disabled and in a great deal of pain. It's just a different kind of pain, such as psychological or distress pain. If physician-assisted suicide becomes more embraced and legalized for being autonomous to the patient, this might lead to many others requesting this end-of-life decision of physician-assisted suicide. And really, what type of society would we be if we encourage people to die rather than to face their own problems?
That's a good point. But after this being said, imagine this very common situation that occurs in hospitals around the country every day. The patient is chronically ill, with death imminently close. The patient is aware and able to make his own decisions. The patient is in the final stages of life and is receiving extremely extensive medical care, is unable to pay for the medical care that he is receiving, and is in extreme pain and suffering. The patient should be able to at least have the choice for physician-assisted suicide. Going back to what John Stuart Mill said about liberty, it is the patient's sovereign right to make this decision for his or herself. Every person has the right to life, so consequently, the right to die.
I agree that patients should be able to have the right to autonomy and decisions related to their healthcare choices, medical treatments, and such. However, suicide is not considered a medical treatment, even with the states that it is legal in. It's a last resort option, though, to a chronically ill patient that will no longer positively respond to any type of medical treatment, with physician-assisted suicide not being a medical treatment. Not that I agree saying with suicide or any degree of it, suicide can and has been carried out quite effectively without medical assistance. Suicide isn't a medical act, and assisted suicide has nothing to do with autonomy as understood in medical-related ethics. Autonomy is the right to refuse medical treatment and the patient's choice, but it's not the right to a non-medical act performed by a physician.
Hi, my name is Rachel, and this is Alyssa, and we will be discussing how palliative care relates to physician-assisted suicide. And I'm against physician-assisted suicide, and Alyssa is for. So, first of all, palliative care nurses, as found in a study, firmly believe that adequate palliative care can remove the need for euthanasia. And euthanasia is only acceptable when palliative care no longer helps the patient. And legalization of PAS requires specific regulatory boundaries. So many Americans haven't been properly educated about the benefits of palliative care, but if they had been educated, then they might have chosen that over PAS, because palliative care can actually have very it can have a lot of advantages for the patient to relieve their suffering. So a lot of patients, it's thought, maybe aren't making a fully informed decision if, they want to do physician-assisted suicide. So a common reason why patients may choose physician-assisted suicide is that they fear an unknown future, and they fear about the pain that they'll experience without doing this, because again, they're not educated about what palliative care can do for them as far as relieving their suffering. And actually, over 90% of doctors working within palliative care oppose PAS, and palliative care is also very different from PAS. With palliative care, the intention is to relieve suffering, which is actually a difference from PAS, as the goal of PAS is to have the patient die. And palliative care also encompasses the actions that the healthcare provider takes to fully understand the patient's suffering. It's thought that a possibility with PAS is that a physician may not be trained adequately in how to talk to a patient who's suffering. Therefore, the physician doesn't know adequately how to explain what palliative care can do for the patient, as far as just presenting other options in general, aside from PAS. And so therefore, it's questioned whether PAS may be a result of doctors lacking empathy for the patient, not having a good enough connection to the patient. And if the provider has empathy, then they can focus palliative care techniques on the patient. And this treatment is better, and therefore PAS may not be the solution. So additionally, doctors may not be properly trained in how to deal with countertransference that is associated with assisted suicide. And with palliative care, doctors are trained better to be able to regulate their emotions so that they can understand the patient better as a whole. And let's see, it seems that the real problem in the medical system is a lack of adequate palliative care. There needs to be better palliative care services in general. However, if palliative care is made to be more accessible, patients are likely to choose that over PAS. And 42% of physicians surveyed in the study reported that there would be no need for PAS if there's adequate access to palliative care. And additionally, these physicians actually had the sickest patients in their practices, so they actually saw patients that were, very close to dying, and who that they could see would benefit greatly from palliative care.
Well, palliative care applied with skill and expertise can address most, but not all, end-of-life suffering, and should be the first thing physicians try for their patients. However, sometimes the pain does not respond to palliative care treatment, or they have nausea, vomiting, wounds, or other things that just does not respond, and it just becomes intolerable and unacceptable. Right now, the main last resort options in the U.S. in order of availability are accelerating opioids for pain or difficulty breathing, stopping potentially life-sustaining therapy such as feeding tubes, voluntarily stopping eating and drinking, palliative sedation, which is progressive use of sedation with benzodiazepines or barbiturates to relieve otherwise intractable physical symptoms in terminally ill patients, and physician-assisted death, which is only legal in Washington, Oregon, and Montana. All of these options seem to make the patient except for physician-assisted suicide. Also, palliative care is unevenly available, and there is an insufficient number of trained subspecialists to meet that need. Only about 30% of dying patients ever make it on hospice, and for some of those 30%, the referral is made for the last hours or days of life. Hospice and palliative care does not change the inevitable fact that the patient is going to die, and if euthanasia becomes an option for terminal patients, then it's possible that doctors who work with terminally ill patients could be trained on how to deal with patients with physician-assisted suicide.
Okay. Well, the percent of patients, the low percentage of patients who have access to palliative care, though, it could be due to the lack of education about the palliative care option. So this lack of education, I think, should be explored and addressed before the decision for physician-assisted suicide. And it's very possible that this new education could change the patient's mind and let them see the benefits.
Okay. In a study looking at 11 years of data describing the practice of physician-assisted death in Oregon, 87.7% of the patients who choose physician-assisted death were actually enrolled in hospice. So they probably were getting the palliative care, and it just wasn't enough for them, and they knew that the end was going to come and didn't want to just extend it for long. And those who were not enrolled in hospice still had access to it, but they choose not to enroll.
Okay. But keep in mind, if there's a focus on physician-assisted suicide as opposed to palliative care in practice, ultimately less resources may be devoted to palliative care, and this may make palliative care inaccessible to patients who would choose palliative care. And also physicians may lose the incentive to research and find better ways to improve palliative care, and explore life-saving options if assisted suicide is a common go-to option. And this will essentially lead to a decrease in the value of human life. And also, a patient who makes a decision to do physician-assisted suicide may be influenced by other factors like depression or something like that. So,
our point is on religion. My name is Catherine Almus, and I am against physician-assisted suicide.
And I'm Amber Gase, and I'm for it.
For the religion point on physician-assisted suicide, there's many different points. You have the Catholic view, which is where it prohibits withholding of food and nutrients and hydration. Anything that would pretty much cause a patient's death is prohibited in the Catholic Church view. So giving a patient the ability to cause their own suicide is very wrong with their views. Also, with the Quran, you have different verses that talk about suicide and murder. One is, "You shall not kill any person, for God has made life sacred except in the course of justice." That point right there says that giving a person the ability to commit suicide is wrong. Also, another one of their points is, "Do not kill yourself. God is merciful to you, but he that does that through wickedness and injustice shall be burned in fire," which pretty much states that if you commit suicide, no matter what, you're going to go to hell and be punished for it. Also, there's the Sixth Commandment, which talks about thou shalt not kill. And in the Bible, thou shalt not kill isn't just killing somebody else. It's thinking bad about somebody. It's giving the person the ability to kill themselves would be considered killing someone themselves. Those who are suffering in a near death should be allowed to die naturally. They shouldn't be given the ability to die unnaturally because it's not right in the religious view.
Okay, the Death with Dignity Act was put into effect on October 27, 1997 in Oregon, and that allowed for terminally ill patients to self-administer medications that would end their life. And the Death with Dignity Act National Center is a very good resource on what religions think about physician-assisted suicide. And it stated that some religions, such as Unitarian Universalist, allow physician-assisted suicide. Religion is a personal choice, as is electing to have physician-assisted suicide. Religion is on a continuum and is very individualized. So, although Catholics don't agree with physician-assisted suicide, a very devout Catholic may want to have that option. From a legal standpoint, abortion is opposed by many religious groups, but it's still legalized in the United States, and abortion isn't denied from people who would want to have one.
I'm Marissa Wood, and I'm going to be discussing the pros about the financial aspect of physician-assisted suicide.
And I'm Julie Turner, and I will be discussing the cons of the financial aspect of physician-assisted suicide.
Okay, the option of assisted suicide would not be one offered until the patient is already in the final stages of life and is no longer receiving interventional treatment. By giving the patient the option of assisted suicide, they would not only be eliminating their pain and suffering, but they're also reducing the financial burden on the family and the use of excessive healthcare resources.
Those who have terminal cancer or other illnesses still sometimes have a chance of living. With the progression of science and medicine, there is often still a possibility, and if they decide to end their life, they'll never know.
The accumulation of health costs accrued by a chronically ill patient as they near the end of their life is astronomical, and it's not taken into consideration that many of the patients and their families are uninsured or unable to pay off their medical expenses, which further contributes to the rise in overall healthcare costs.
Patients shouldn't be guilted into euthanasia just because they can't afford their medical bills, and if euthanasia is legalized, patients may be put in this position. Death may not be needed, but chosen for the wrong reasons. It is expensive to treat chronically ill patients, but giving patients the option to die could negatively impact doctor-patient trust because the patient could think the physician had an ulterior motive if he or she provided euthanasia as a treatment option. The cost of weakened trust in the doctor-patient relationship could far outweigh the benefits of assisted dying, particularly given the importance of trust when treating a chronically ill patient for an extended period of time.
As you can see, physician-assisted suicide is a very controversial topic and can be argued well on both sides. The 4 topics of patient autonomy, financial issues, religion, and palliative care that we discussed are only some of the contributions to the ethical dilemma of physician-assisted suicide. Thanks for watching.